I'd like to welcome Dr. Carol Redmond to our class today. I'm just going to talk a little bit about Dr. Redmond. She went to medical school at U of T in 1980, or graduated from, I should say, and did an OB-GYN residency at U of T from 81 to 85, then an REI fellowship at U of T in 85 and 86, and a Ped Gynae fellowship at U of T in 86 and 87, and then an REI fellowship at U of T again in 87 and 88, and then OB-GYN, and then she started her private practice in OB-GYN and reproductive biology at St. Michael's Hospital from 1988 to 1994, and then moved into a reproductive biology practice at START, later known as LifeQuest and now Trio, from 1994 to 2011, and then moved on to Hannum Fertility Center from 2012 onward, where she is today. And she's had as you can see, she's had quite a long and productive career. She's very lucky to have had 4 children without the help of ART, and she says she will work forever paying for the education of these 4 children, so it's great that she loves her job. Today she's going to talk to us about IVF, an overview for naturopathic doctors, so I want to hand it over to her. Thank you so much for coming today.
Good afternoon, everyone. So the focus of this talk is about using IVF as a treatment for subfertility, but first I'm going to have a brief overview about fertility issues in general as a background. What we need to know about human beings is that we are not a reproductively efficient species. Most long-lived species aren't. It usually takes a lot of eggs to make an embryo. And as you can see, cyclofecundity means the chance of conceiving on any single time that you have sex when the egg is there. And the chance per month when you're 20 years old, which is not when anyone's trying to conceive anymore, is still only 1 in 3. By the time you're 30, which is the average age at which people start trying to conceive now, you're down to a 1 in 5 chance of conceiving. I think I said 1 in 30. I meant 1 in 3 chance at 20, 1 in 5 chance at 30. By the time you're 35, you're down to a 1 in 10 chance of conceiving. By the time you're 40, the odds are dropping off, as you can see. And this has to do with the change in egg quality as women age. And women come into the office all the time in their 30s and say to us, okay, now I know that guys have sperm that they make every day of their lives and they're fertile forever, but that women are born with all their eggs and the egg quality is dropping and the egg numbers are dropping as I get older. I want you to do that test my girlfriend did and find out how much time I have left in the biological clock, because then I can make plans. So tell me how fertile I am and how much time I have. And the problem is, there is no such test. You cannot assess how good the egg quality is, and you cannot monitor how quickly it's declining. So the AMH test to which your friend is referring does not tell you about fertility. It does not tell you about egg quality. It's useful for a lot of things, but that's not what it tells you. And people often also feel that as long as their cycles are regular, they're fertile. But there's a great number of years in your 40s when your cycles are still dead regular, but egg quality is no longer any good. So regular cycles are a minimum requirement, but they don't tell you about egg quality. Things that cause you to have subfertility, I put into 3 groups. 1 is mechanical. For some reason, sperm and eggs can't join, either because you have low sperm numbers and the sperm don't function properly and can't get to the egg, or you have fallopian tubes that will not allow the sperm and eggs to meet because they're non-functional or blocked because of infection or endometriosis or some other issue. Or you have an ovulation problem with irregular cycles, you're not making an egg, there's nothing for the sperm to meet. Or there's structural problems inside the uterus. And the pictures on the screen show a fibroid on the upper picture indenting into the cavity, and on the lower picture, polyps in the uterus. And these act like stones in a garden. If the embryo tries to implant on top of a polyp or a fibroid, it just won't implant. So what you find is that if a couple is 30 years old, 80% of people will get pregnant without any sort of assistance. Within 12 months, they're going to conceive. Now, it may take up to 12 months because of that biologic inefficiency I told you about, but it will succeed. And the 20% of the 30-year-olds who don't get pregnant generally have a mechanical problem. Something with the tubes, something with the sperm. By the time you're 35, only about 60% of people get pregnant and 40% of people walk through the door of a fertility clinic. So on top of those mechanical issues, you add the growing problem with depleting egg quality. And by the time you're 40, only 40% of couples will manage to do things on their own and not have to see a fertility clinic. And the important thing about the 40-year-olds is that they often come in and say, no, I can't have an age-related problem because I have lots of girlfriends my age who are pregnant. And that is true. As we just said, 40% of people do conceive, even at 40 on their own. But more people have a problem than don't. Age is a considerable impediment for many. Egg quality issues do also occur in younger women. 1 in 10 women will be having menopause early, and if menopause comes early, egg quality issues happen early. Not as common as the mechanical problems, but there's no age at which you can rule out a problem with egg quality. And the issue that the inefficiency in reproduction and the change with age is all about eggs. And it's important to note that this is not a pathology. This is a natural evolution. This is a natural aging event. Eggs change with age the same way all the other cells in your body do. And there isn't anything that makes them better. If we had a treatment that made older cells more competent for longer, we'd be using that treatment for our brains and for our hearts. So there's nothing that can rejuvenate your eggs and bring them back to where you would like them to be. And it's a popular misconception that if you simply stay fit and healthy, that is going to contribute to prolonged life of your eggs, prolonged healthiness. And it doesn't. It certainly helps your heart, it helps your bones, but it doesn't contribute to eggs staying stronger for longer. They're going to decline whether you're fit or not. And it's also important to note that fertile once is not fertile forever. If you've had a baby, that's great news because it means your tubes work, your sperm work, you ovulate. But at some point, all women with good egg quality will have 100% bad egg quality. So all fertile women will with time become infertile. It's just a matter of when. When we're treating fertility problems, of course, if we have something to fix, we fix it. If there's polyps or fibroids, we take them out. If there's an ovulation problem, you go on fertility pills to make you ovulate. If there's a low sperm count or a problem with fallopian tubes, you go directly to IVF because you cannot primarily take damaged tubes and undamage them. You can't fix them. And with low sperm numbers, we don't have any mechanism yet to improve sperm numbers or make sperm function better. So we simply go straight to IVF and put the sperm right inside the egg if a natural conception isn't occurring. I'm going to skip over number 3, insemination or sperm wash, and address it briefly later on, but now I'm going to IVF because that is the focus of the talk. IVF used for fertility problems. And these are the indications for going ahead with IVF. Problems with the sperm. And what we found is that men with low sperm numbers, along came IVF in the 80s, and we thought, fantastic, these guys with low numbers, the sperm just can't make it to the egg. So we took the eggs out and we dumped the sperm in the same dish as the eggs in the IVF lab, and we watched while 8% of them refused to join with the egg. So when you have compromised sperm numbers, you very often have compromised sperm function. It's not just that they can't get where they need to go, they won't attach to the egg and they won't enter the egg. So IVF didn't work for male factor at first, and then along came ICSI, and ICSI is Intracytoplasmic sperm injection, putting a sperm inside the egg. And that worked really well. So since 1994, we've had a great treatment for male factor, IVF and ICSI. In fact, it has a better pregnancy rate than any other indication for people using IVF. Of course, if you have blocked tubes, IVF was first developed to deal with people with blocked tubes. You got eggs in the ovaries and sperm in the uterus, and they can't meet because the tube is blocked. So you bring both the eggs and the sperm into the lab, make the embryo, and put the embryo back in the uterus. It works very well for tubal factor. Then the third reason, unexplained infertility, I want to spend a little time explaining unexplained infertility because it is a very confusing concept. So people will routinely come to me saying, I've been trying to get pregnant for 18 months. My ovulation is normal, his sperm are normal, our tubes are open, and the last doctor told me, we're normal, everything's okay. And that's not so. Something's not okay. You've been trying for 18 months, you should be pregnant. What we have tested is okay. The problem is what we can't test. And there are big things we can't test. So if you have normal sperm numbers, we don't know the sperm work. They should, but we don't know that they do. We don't know if they actually make it to the egg. We don't know if they can fertilize the egg. In fact, if you take couples with unexplained infertility and do IVF and put those normal-looking sperm in the dish with the eggs, 1 in 4 times, there will not be fertilization. So you can have big functional problems in the presence of normal sperm numbers in a group of men. You can have problems with fallopian tubes that are open that don't move to go collect the eggs. Fallopian tubes do a very important function. They're complicated. They get the eggs, they're silly inside them to move the sperm and eggs together. They're the environment where the embryo lives for the first 5 days. So an open fallopian tube may be compromised inside in ways that we simply can't assess. Egg quality can be compromised. You cannot tell that by the hormones of the cycle. Hormonally competent cycles can have eggs of poor quality. The endometrium may not be able to implant an embryo. This is just a partial list of really big problems that can be occurring that are not picked up with our current technology. So normal testing does not mean you're normal. It means the testing hasn't disclosed to us what the problem is. But the good news is that of all those things, IVF fixes them. If your problem is sperm that don't work or don't get to the egg, we can take care of that. Fallopian tubes that don't let the sperm and eggs meet, or a bad environment for embryos, we can take care of that. Eggs that aren't good quality, well, IVF does not make better eggs, but it allows you to work with multiple eggs at a time, so if you have a low percentage of good eggs, you can get to the winning egg faster. And that segues to number 4, which is age-related subfertility. If you're over 35 and all your testing is normal, you're not getting pregnant, the problem is egg quality in my mind until proved otherwise. And IVF comes into the picture, as we just said, by allowing you to make many eggs at one time without a fear of multiple births and getting to the winning egg faster. And of course, the last indication for IVF is if you want to preserve fertility, if you want to put eggs or embryos in the freezer for future use. And the freezing technology, we've got that nailed now. So fertility preservation is a very viable and effective option now. What we struggle with in IVF and on our own naturally is that we're not an efficient species. So if you have in IVF 100 follicles to drain, you're not going to get eggs out of all of them. Of all the eggs you get, only a certain percentage are going to actually be mature eggs. Of all the mature eggs, only 85% are going to fertilize, even if you put the sperm right inside the eggs. And then the biggest drop-off is how many fertilized eggs actually become blastocysts or embryos. And the percentage of your eggs that can make a blastocyst, that's your personal egg quality. And there's no way to know that before you do IVF. You can't tell that from your cycle or your AMH or your age or anything else. So women with good egg quality tend to make more blastocysts out of their eggs. Poor egg quality make poorer blastocysts out of their eggs. But you're not going to know what your yield is until you actually do IVF. So you enter IVF not knowing what your personal odds are. I can tell you if you're in a good prognosis group or a bad prognosis group, but I can't tell you how you're going to do until you actually go ahead. And then of course, not every embryo that you make that looks normal implants. So the part of IVF that people like the least is that we don't go and take out the one egg that you make at a time. One egg, as we've seen, is a very inefficient thing. We want to have multiple eggs, and that means that we're going to deliberately superovulate the ovaries. We're going to get them to make more than one egg at a time. This is a completely non-physiologic event. Ovaries are never meant to do this in nature, but some of them do it pretty well, and that allows us to work with multiple eggs and improve the odds we're going to have at least one competent embryo. And what we're going to, sorry, we're just doing a sound check here, so we have a brief gap here.
Sorry, please excuse the, okay. Great, just double checking that we're capturing all of that. Sorry for the interruption.
That's okay. We had an interruption because we had a glitch before. This is our second time recording this. We just want to make sure we're really recording. So the stimulation process is the part that's the work part of IVF. Women have to inject with FSH hormone, a natural hormone, every day for 10 days, 8 to 12, but usually 10. Come in and do bloods and ultrasounds for most of those days to try and grow the multiple eggs. So you take 10 days of hormones. On the 12th day, you have your egg retrieval. We no longer do a fresh embryo transfer. We make embryos and we put them in the freezer, and we take them out of the freezer and put them in at a different time. And I'm going to tell you why that is now a little bit later. Before we do the stimulation, we usually do what we call downregulation. It's a month when people are on the birth control pill before they start that process of injections. And it's all about scheduling. So the IVF success rate has entirely to do with the quality in the IVF lab. And the IVF lab cannot give us good quality for asking them to do 17 retrievals in one day. So what happens if 17 people call in and they say, today's my period, and we have to link in with a cycle, those 17 people will all be retrieved on the same day, and that's not possible. So all 17 go on the birth control pill, and then we stagger when we take them off the pill to start the injection, so we can stagger when they're going to have their retrieval. And when we do this, we can have the best quality in the lab, so that's in everyone's best interest, to not stress the lab so they can give us the best possible results. We usually use birth control pill in older women. Sometimes we use estrogen and progesterone because it also shuts down the ovaries and keeps you from ovulating, and a little bit of androgel, that's a typo, because older ovaries often respond better to stimulation if they've had a little bit of male hormone temporarily before the cycle. The FSH has to be given as an injection, which sounds very intimidating, but the injection delivery device now, that the pen is really great. It's like an EpiPen or an insulin pen, so it really is very easy to do. And we've used, over the years, many different FSH products. At first we thought it had to be FSH and LH that we got from other human beings. And then we thought, no, it has to be pure FSH that's recombinant in the lab. And now we're back to actually a little bit of both is what we want to do. So the current regime is that we give one of column A, Gonalef, Puregon, Retrieval. Those are the brand names, and quite frankly, they're all indistinguishable to me. I use them interchangeably. Don't tell the drug companies. So those are the column A, and then you use one of Menopure Repronex, which is a little bit of FSH and LH from a human source, or you can just get pure LH made recombinant in the lab. So that's what they're injecting with every day. The dosage is dependent on the AMH and the weight, and this is where AMH comes in. It is very valuable to us because women with high AMHs make more eggs at a time, and women with lower AMHs make fewer eggs at a time. Now, on the left-hand side, that's someone with a low AMH making us 3 follicles, and on the right-hand side, that's someone with a higher AMH making many follicles. Now, I do not know what the quality of the eggs are in those follicles. The person on the left may be the one who gets pregnant, and the person on the right may be the one who doesn't. But it feels better to work with more eggs because of that drop-off. So we take a look at the weight, and we take a look at the AMH, and that's how we gauge the correct dosage to give somebody. FSH is great in that you don't get side effects from FSH. You don't feel FSH in your system. It doesn't cause rashes. What it does is it grows eggs, and that you feel. So the more eggs you grow, the more you feel. So your ovaries become enlarged, and you get bloated for a couple of days before the retrieval. Then we do the retrieval, we puncture the ovaries, so there's little bruises all over the ovaries, so it's sore and crampy for a couple of days after the retrieval. And then when you ovulate many eggs, you have much higher progesterone levels. And high progesterone levels, bowels hate that because they cause constipation, they cause your bowels to stop dead, you get loops of distended bowel, you get bloated and uncomfortable. So 4 to 5 days after the egg retrieval is when you have your worst symptoms, your most bloating, and then 7 days after the egg retrieval, it all starts to recede and you start to deflate. And that is basically mild hyperstimulation syndrome, ovaries getting big before they get small. And what used to happen when we did fresh embryo transfers is that your maximal ovarian size is 5 days after the retrieval, and that's when we put an embryo back in. And if it worked and you got pregnant, pregnancy hormone drives the ovaries to get bigger, and you get these enormous ovaries. And if they got big enough, they'd exude fluid from the surface, and you get ascites. If you got big enough ovaries and enough ascites, you could get third space loss and intravascular compromise. People got hypercoagulable, they had strokes, they had decreased intravascular volume, they had renal failure. People with bad hyperstimulation in the 60s when this started, some of them died. Certainly many were hospitalized. Hyperstimulation was a very significant event. So it can only happen if you're pregnant when the ovaries are big. So don't put an ovary back in. And until we got good embryo freezing, we didn't have a choice. Embryos did not survive the freezing process the way that we used to do it. So you put in your embryos and you took your chances. Now with great freezing programs, we don't have to take the chance. So we don't do fresh transfers. We stimulate the ovaries, let them settle down, put the embryos in a freezer, and put the embryos in at a different time. And the advantage is that you don't risk severe hyperstimulation syndrome. You may be uncomfortable, but not severe hyperstimulation syndrome. And your discomfort is quite temporary. And because it's a much more natural environment. Those high estrogen and progesterone levels of a superovulation cycle were never ideal for embryo implantation, but we got away with it. We have better implantation rates if we put the embryos into a much more natural environment, which we do on a subsequent month. When we superovulate the ovaries and make multiple eggs, we do not use up eggs and make someone go into menopause faster. We don't take someone with a low AMH and make it even lower. That's not the way ovaries work. So taking out 10 eggs does not mean that menopause is going to come 10 months faster. It doesn't work that way. And the temporarily higher hormone levels do not change your long-term lifetime risk of hormonally dependent cancers like breast cancer or uterus cancer or ovary cancer. Even if you have breast cancer in your family, this does not increase your risk. The risk of the process is that you have to put a needle inside a body cavity to take eggs out. That cannot be risk-free. It's low risk, but it's not no risk. There's about a 1 in 1,000 chance of bleeding from the ovaries when you puncture them, or infection because you have to go through the vagina, which of course can't be sterilized. This is a diagram of the egg retrieval, and as you can see, as the ovaries get bigger and full of eggs, they come down close there to the top of the vagina, which is easily accessible with that transvaginal probe. And the transvaginal ultrasound probe is showing you where you don't want to put the needle. It's showing you where the bowels are and the major blood vessels and where the ovaries are. And in the bottom left-hand side, you can see part of an ovary with those 3 black circles and a little line coming in from 12 o'clock, and that's the retrieval needle coming into the sac of fluid. On the bottom right-hand side, you can see the diagram showing the sac of fluid is the follicle with the egg in. And as the fluid comes out, the egg comes out with it, and that's how you collect your eggs. This is done under conscious sedation, so though everyone worries about it, they're not out cold, but if you give midazolam and fentanyl, you don't remember. So the whole thing only takes 10-15 minutes. And you have conscious sedation on board, so like getting your wisdom teeth out or getting a colonoscopy, you don't remember the process. And once the eggs are out, you're done. Everything else happens in the lab. The eggs are fertilized, and we wait 6 days for them to become embryos. Let's talk a little bit about ICSI, or how we fertilize eggs. ICSI refers to intracytoplasmic sperm injection that we referred to earlier from male factor. And we use ICSI if we know that there's a low sperm count and therefore a high chance that the sperm do not function properly. And we can get people pregnant if they have really, really low sperm counts because all you need is 1 sperm for each egg. So if a woman has 12 eggs, we need 12 sperm, not 1,200, not 12,000, not 12 million, a very small number. So it has enabled us to take men with sperm counts that are impossibly low, that could never have had a natural conception, and allow them to conceive where they couldn't have in the past without going to donor sperm. And that was why ICSI was developed, was for low sperm numbers. It also is good for those 1 in 4 couples with unexplained infertility with a fertilization defect. The problem is, you don't know who those couples are in advance. There's no test to say, you have unexplained infertility and yours is because the sperm look great but don't work. And what used to happen is we'd do the cycle, we'd take the eggs out, we'd put the sperm in the dish, and this still happens in countries where this is funded, and you wait 24 hours. And if you check the next day and there's been no union, you say, congratulations, we know what your problem is a fertilization defect. However, we have no embryos, so we're going to start all over again next month. In places where this is funded, that is often still what they do. You have 1 trial cycle that gives you an answer sometimes, that is, you have to do things differently the second time. In North America, where you only have 1 funded cycle, or you're paying for all your cycles, the concept is that you really don't want to take a chance you're that 1 in 4. That by the time you find out that you do not fertilize, we can no longer do ICSI for that cycle. So if you have unexplained infertility, I generally recommend that you do ICSI, because I don't know if you're the 3 out of 4 where you probably didn't need to, or the 1 out of 4 where it's going to be a critical step that we don't want to miss. Then lastly, if you're doing embryo screening, you can see the egg there on the screen, and if we'd allowed it to naturally fertilize instead of putting that little pipelle in it, which we inject the sperm through, there's a lot of sperm heads stuck on the outside, because a lot of sperm try to get in the egg and only 1 does. And all those little sperm heads stuck on the outside of the egg can mess up your genetic biopsy that you do later on the embryo, because the genetic material from the sperm heads can get in the way of the genetic material of the embryo. You can't tell which is which. So if you're doing embryo screening, there's a strong preference to do not natural fertilization, but ICSI, so you have a clean entry of 1 sperm in and nothing else cluttering up the outside of that egg where you're going to be doing a biopsy later. So when all the dust settles, most couples now qualify for ICSI. Most fertilizations, at least in our lab, because we do a lot of embryo screening, and because there's a lot of people with unexplained infertility, and because of sperm issues, do end up getting ICSI. Couples with blocked tubes, couples with ectopics, don't necessarily have to do that, but they're less common. I'm now going to talk about screening the embryos. Because what has happened in the past is that you fertilized eggs and you wait 5 days and you make embryos. And this is the difficulty, and I'm going to skip through to the next slide. This is the difficulty with human eggs, is that as you can see from the box in the bottom right-hand corner, that if you have a bunch of eggs, and an under 35-year-old is going to have 10 to 15 eggs in IVF often, only some of them become embryos. You can see their average number of usable blastocysts is 5. So a bunch of eggs, only some became embryos. And then of those embryos, human eggs make 2 kinds of embryos. Euploid embryos. These are genetically competent 46XX, 46XY. And aneuploid. These are embryos with 45 chromosomes, 47 chromosomes, wrong number. That's what aneuploid means, is wrong number. And aneuploid embryos have 0 chance of ever being a human being. Aneuploid embryos will either fail to implant or they will miscarry. Or uncommonly, an aneuploid embryo is Down syndrome. It's the only common aneuploidy that actually is viable and can make it to term that you ever heard of. Turner syndrome and Down syndrome, but most often aneuploid embryos don't make it to term. So whether you're trying naturally or you're trying through IVF, some of your eggs become embryos and a lot of those embryos aren't normal. And the difficulty is when you're looking down the microscope is that a euploid embryo and an aneuploid embryo look exactly the same. You cannot tell. So what we used to do in the past is we just kept transferring. You did multiple transfers until you eventually got the winner. Or, because that's exhausting and expensive, you don't do 1 embryo at a time. You put in 2 at a time or 3 at a time, betting that they're not all normal. And as you know from the past, we often were wrong. They were all normal and people got twins, people got triplets. And although twins, no one wants triplets of course, but although twins sound like a good idea, they're a risky pregnancy. They're not what you want. There's a higher risk of twins having lifelong problems. Twin pregnancy was always a side effect and never desired outcome. So what we lacked was the ability to tell which embryo to put in to have a high pregnancy rate without risking miscarriage. Without risking failure. And now that we can screen embryos, it's made all the difference because each single euploid embryo gives you a 60% chance you're going to have a baby, independent of the age at which you put it in. So if you have a euploid embryo banked when you're 35, you can put it in when you're 45 and still have a 60% chance of getting pregnant. So euploid embryos lower the level the playing field. What becomes difficult is making them. So as you can see in the 35-year-old age group, 70% of embryos will be euploid and 25% will be aneuploid. Look what happens as you get older. Now about 60% of embryos are okay and 40% aren't. 38 to 40, only 40% of embryos are okay and 60% aren't. By the time you're over 40, 3/4 of your embryos will never become a human being. So once you have a euploid embryo, no matter how old you are, you have a 60% chance. It just gets harder and harder to make a euploid embryo. And so the value of embryo screening, particularly for the older women, is let's say this 40-year-old woman made 4 embryos and only one of them is normal. And you didn't do embryo screening. You put in embryo number 1, it doesn't implant. That's 1 month of her life. You put in embryo number 2, it implants, but it miscarries. Because aneuploid embryos are the main reason for miscarriage. There's another 3-4 months of her life living through the miscarriage. You put in the next embryo, it miscarries as well. Now, of course, she feels there's something wrong with her, what's wrong with her uterus, and months have passed before you finally get to the winning embryo. So aneuploid embryos don't just break your heart and give you treatment fatigue. They waste valuable time, particularly when you're older. So embryo screening is particularly valuable for the older women where miscarriage is just so common because of embryo aneuploidy. Now I'm going to go back a little bit, and show why we can do embryo screening without hurting the embryo. Because by the 5th day post-fertilization, you've gone from 2 cells to 7 to 8 cells, and by day 5 you have hundreds of cells, and they make a blastocyst that looks like this, with a ring of cells around a fluid cavity in the middle. Those ring of cells, that's going to be the placenta, and that little blob at the top is the inner cell mass, and that's going to be the baby. So you take 5 to 7 cells off from the trophoblast, from where the placenta is going to be, and in 95 to 97% of embryos, that's enough cells to get a read, to get an indication if it's 46XX or 46XY. But you don't damage the inner cell mass, the baby, and you don't compromise the viability of the embryo. So embryo biopsy does not give you a lower chance of getting pregnant by damaging the embryo. It gives you a higher chance of getting pregnant by leading you to the winning embryo faster. And one note is that the lab will have a result of 46XX, 46XY, but in Canada, it is illegal for them to tell us the sex. They can simply tell us that the embryo is normal. You cannot do gender selection in Canada. If you want that, you would have to go to the United States, where in many clinics they do that. Not all, but many. Then I said before, I double back a little bit to the sperm wash option. That's the top right-hand corner, insemination IUI with 1 to 3 follicles. And what that means in real time is you take a fertility pill, even though you ovulate, you take sperm that looks normal, and you move it up in the uterus. And we're thinking, well, maybe there's a bit of a subtle ovulation problem, maybe a bit of a sperm delivery problem. And you can see it could fix those problems. You can see a lot of problems it won't fix, tubes that don't work, sperm that can't fertilize eggs, eggs that aren't good quality. And its success rate reflects the fact of the number of things it just doesn't bypass. So it has the advantage of being natural and easy and inexpensive, and the major disadvantage of just not working very often. The pregnancy rate, as you can see with the sperm wash program in the right upper hand corner, is only about 10% per try. And after 2 tries, we stop doing it because it's no different than the natural conception rate. So the dilemma is, nature is inefficient, but the way you want it to be. And it's easy, and it's low side effects, and it's low risk. IVF is what works, but it's not natural and it's not easy. And you want some treatment in between that's a simple pill but works really well, but there isn't. You either take a simple approach and accept a lower pregnancy rate, a much lower pregnancy rate, or not simple approach if you want the best pregnancy rate. Then I'd like to speak a bit about miscarriage, because once we've been doing embryo screening, what we've discovered is that miscarriage is almost always about the embryo. If you take out the aneuploid embryos, if you screen the embryos just for that, the miscarriage rate drops to 10% in all age groups, keeping in mind that if for a 40-year-old, the miscarriage rate is 40 to 50% naturally. So miscarriage is about embryos, and my view is that 10% of euploid embryos that miscarry, I still think it could be about the embryos. Because checking that they're 46XX and 46XY is still a superficial assessment. We can't check them at the gene level. We can't check that they're metabolically competent. We can't check that they're immunologically competent. It's like looking at you and saying you're 46XX or XY, therefore you can never have diabetes. Embryos must have other compromise. We just can't check them any more deeply. And we know that if we have enough euploid embryos, most people do get pregnant. So miscarriage is almost never about the mother. So it's been a huge paradigm shift. So despite in the past we've always viewed it as it was that you were stressed, it was your progesterone level, it's that you needed aspirin, it was that you are immunologically compromised and you're rejecting your embryos, it's that your uterus we blamed the woman for the miscarriage, that in some fashion we couldn't always discern. She was hostile to embryos. She was a bad place for embryos. And it's actually not about the woman at all. It's about the embryo. In fact, to me, if you've implanted at all, it says actually a good place for an embryo. We know that human beings make many, many abnormal embryos. That's our deficit. And that miscarriage is the solution to the problem of making a lot of abnormal embryos. And this is why progesterone and blood thinners and heparin and immunoglobulins and all these things haven't made the impact we wanted them to make, because we've been barking up the wrong tree. There may be a tiny subgroup still, but it's really mostly about embryos. And what that means is that when people come and say, well, I've had 2 losses, I can say, well, this is the good news. Obviously, you can get pregnant. The sperm, the tubes are open, you ovulate, you can implant a pregnancy, all good news. The bad news is that making an abnormal embryo is completely random. I can do nothing to change your odds of doing that next time. Now, the odds are in your favor, but I can't make them be in your favor. I can't do anything to you to make you carry that next pregnancy. We're just counting on the odds. The only thing you can do, the only thing that's been proven to lower the risk of miscarriage is don't do it naturally. Go to IVF and screen out the embryos that with certainty will miscarry. So it is a very valuable, it's particularly in older women, to try and minimize miscarriage. It's just not what anyone's preferred route of trying to conceive. Everyone would really rather that things were done naturally. So IVF has come a long way in my practice, from when it didn't work very well at all to now when it works really, really well, and also gives you the option of banking embryos, particularly if you're younger, so you can achieve more than 1 pregnancy with a single IVF cycle. You can stave off the changes of the biologic clock by having an embryo bank that has a 60% chance no matter how old you are. It's made great strides. The problem is that it's not natural. And no one wants this process not to be natural, and nature, unfortunately, is not very forgiving to everyone. But if you're in the position where nature has not been accommodating you, you at least can know that we do have technology that actually now has an extremely good chance. If you have to commit to something that you don't want to do, you at least have an extremely good chance that it is going to work for you. So that concludes the presentation, and now Zainab and I are going to have a little talk about the interaction of fertility clinics and naturopathic doctors.
Great. Thank you so much for your presentation, Dr. Redmond. I'm sure it's been so fascinating for you to see the evolution of this technology over the course of your career.
It's been amazing. It's been night and day between when I started and how things are now.
And you can, I'm sure, feel so good about helping so many more couples who come to, or individuals or couples who come to see you.
Yes, I don't want to retire now. It finally works. Things really work now.
I wanted to just ask you about your experiences working integratively, specifically with NDs. Over the course of your career, what has been your experience in integrative care?
Yes, so this is what I love about the naturopathic approach is that patients love it. Patients really need this process to be as natural as possible, and unfortunately, if you've walked through the door of a fertility clinic, your nature probably isn't accommodating. And we know that people are inefficient, and this process often takes quite a while. And to work with a naturopath can give them a great sense of control over this issue that isn't as controlled as they need it to be, but to be on top of their health, on top of their diet, on top of their vitamins, acupuncture, all these things give them a sense of being more in the driver's seat when they're in this terrible predicament of not getting pregnant naturally. I really, really like acupuncture too. Great for pain, great for irregular cycles. I don't know if it improves pregnancy rates, but what it does do is it improves the stress around the processes you're going through to get pregnant. It's great for that. And it may improve pregnancy rates. Some studies say yes, some say neutral, but none of them ever say it's bad. So I'm very, very pro acupuncture.
That's great. Those studies can be so hard to conduct, especially in terms of the control group. So that's a challenge in that area. What have been, you've spoken to sort of the positive outcomes you see of patients experiencing integrative care, and I think we talked in our first recording about how, we know that stress isn't the cause of infertility, but it definitely can lead to a higher dropout rates of treatment, especially in individual, not especially, but also in individuals or couples where eventually IVF may be successful.
Yes, yeah, absolutely. So it's important that couples understand that this is not about stress, because people frequently come in and say, well, the year I had last year, there's no way I was going to get pregnant. Well, unless it's keeping you from having sex. Stress doesn't keep you from getting pregnant. Teenagers wish. So you don't want to focus on what isn't the problem and avoid dealing with what you need to deal with. It's often age, for instance. You want to get right on top of that. But this is really stressful, and it often carries on, and it's not happening in a bubble. The process of subfertility is enormously stressful, and then your job is whatever it is, and your family is mean to you, and all sorts of other things are happening. And anything you can do to minimize your stress can help you endure the process, because it's a very uncomfortable way to live with a lot of internal stress, and you have to do it quite often for many, many months, and anything that can help you moderate that is a good thing.
I wanted to ask you a little bit about what have been the negative or less desirable experiences you've had with patients seeking naturopathic care.
Yeah, uncommonly, some of the problems that I've had is when I don't understand the diagnosis. So if someone comes and said, I've been told that I have adrenal fatigue, or their cycles are regular, but they've been told that they have imbalanced estrogen or progesterone, or they need to be detoxified, and I don't know what to do with those, keeping in mind that what they think they've heard and what has been said to them may not be the same thing. It's difficult if I don't understand the diagnosis, because I don't want to say, golly, you've been told something that's just silly. I don't know what they've been told, and also to have two caregivers that don't agree makes them anxious. Why don't I know what you're talking about? Why don't I know what you're doing? Why don't you know what I'm talking about? And you don't want to foster that sort of environment that there's any sort of confusion around their care.
Yeah, definitely. I think fertility challenges are stressful enough.
Yes.
That's the last thing they need, is to feel conflict between the information that they're being given.
Yes.
So what do you think naturopaths can do to foster a more positive and collaborative working relationship with MDs?
Yes. So communication. So little notes that say what you're doing, particularly if you're planning acupuncture, what your your process for it is. I want to do it for an hour before the retrieval or an hour after the transfer or whatever, so we can make sure the clinic can accommodate that. I do a note that the patient has, they get a copy of, that they can share with you. Sharing blood work has always been difficult because it meant we had to copy everything, which is just an administrative task that was annoying for the clinic. But if people can now get online to get their bloods, it's going to make things a lot easier. So that, and then I keep forgetting because I'm so old, there is email. Email contact is not a bad thing. I've got on this last slide my email contact me and say, listen, this is what I'm planning, or this is what I've told the patient, or this is what I think they said you're doing. Is any of this right? Communication is never a bad thing, that we all know what the other person's doing and what their intentions are.
Right, and I like that you said, the perceptions of the patient, because I think we've all experienced that sometimes patients misunderstand you or hear the things they perhaps need to hear or want to hear. And so I think it's also important for myself and my colleagues to remember that works both ways, and what the patient hears from you might not, what they say they've heard from you is not always completely accurate.
Right, you must have run into this, because we all do. Someone comes back and says, well, you told me, and I thought, no, I never said anything even kind of like that. And you have to remember that they interpret everything through the veil of what their fears are, what they think is going on, what they're most afraid of. So they don't always hear accurately, or you haven't communicated accurately, and you have to give it another go, one or the other.
Yeah, definitely.
And give it another go. You were also asking me before if there's anything lifestyle that you can do other than smoking. And the important one, I think, is weight. Not what diet is. It doesn't matter if you're vegetarian or not vegetarian, but what you weigh matters. That we know that the higher the BMI, pregnancy rates drop, miscarriage rates rise. It can be harder to do procedures. Drugs dosages are higher. And then once you are pregnant, there is a higher risk of pregnancy complications. And so BMI being as close as it can be to the normal 19 to 25 range is always good, and obviously really hard to do. No one is at a high BMI on purpose. They need help. They need a hand. They need someone in the ring with them. So that is a very valuable service for people trying to conceive.
And I think we mentioned in our previous recording also that we see patients over the course of fertility treatments gain weight because of sometimes the restrictions around physical activity, or just the stress that might lead to increased portion sizes or emotional
more cake. That's what you do when you're stressed. More cake.
So we've seen that a lot. And I think we acknowledge that you're perfectly well trained to help them through that, but you just don't have the time to spend with patients, and that's where we have a huge advantage, is we have so much time to spend.
I'm actually not perfectly trained to help them through that. I'm counting on you.
Well, thank you. And thank you again so much for your time. It's been fascinating to hear you speak about the evolution of this field and the technology over the course of your career, and to shed light on those changes. And so thank you for that. And thank you so much for your time in the first recording and this recording as well. I really, really appreciate it.
My pleasure. And there's my email address if anyone ever wants to ask me anything.
Okay, great. Sorry, I'm just gonna shut the recording off here.
Did we get it?